Thank you, ma'am, for the introduction. And I'll take you away from full field ERG into another specific test, which is the multifocal ERG and pattern ERG. So why do we need multifocal ERG? As we saw Dr. Purnachanda tell us such a good cases that we had, that it gives you so much of information, then what is the need for another test? So the reason we need it is that full field ERG is a global response, and sometimes focal or smaller area, if it is affected, that gets missed. And to address this, we have other investigations. And full field ERG measures both rod and cone responses. Multifocal ERG is largely cone-driven, and electric activity of the entire retina is measured by full field ERG, and simultaneous measurement of multiple retinal responses at different locations is done by multifocal ERG. So full field ERG is a true response, but multifocal ERG is actually a mathematical extraction, and we'll see in the subsequent slides how this is done. Main thing, as Dr. Subhadra ma'am was talking about, you need to know how you are going to do it. So this is a protocol of recording all these tests is laid down very nicely by the ICEF standards. And as recommended by the ICEF standards, the pupillary dilatation is important. Patient should be light adapted, in room illumination, and usually it's 103 hexagon stimulus, which is done monocular recording and with refractive error correction in place. So this sort of sums it up. This is the kind of stimulus that you have, and once the electrodes are put into place with an amplifier, this is the response which is generated by the computer, and then it is further digitally analyzed. Importance is good fixation, and good fixation can only happen with good visual acuity. So as Dr. Subhadra said, if the patient has poor vision, neither can you elicit a pattern ERG nor can you elicit a multifocal ERG. Usually a vision of 20 by 200 is considered a cutoff. If the patient has vision less than this, he or she may not be able to fixate the fixation target, and you will not get any useful multifocal responses. As we said, that refractive error correction should be in place, but when you put the patient glasses or your trial frames, sometimes because of the peripheral blockade, you may not see that very clearly, and it may show as a rim effect, and the patient may not be seeing the stimulus through that, which means it will show areas of depression. So this is the kind of stimulus which is there, which is very different from the typical light flashes which we are used to. So because it elicits response from 40 to 50 degrees, we know it is the central area which is stimulated, and that is largely dominated by cones, plus we do it in light adapted conditions, so it is the cones which are responded. So you can see that the size of the hexagons is not uniform. Some in the center are smaller, peripheral ones are larger. This is to follow the physiological distribution of the cones. As we know, in the center, the cones are much more in number and concentration as compared to periphery. So as a result, each hexagon, whether it's in the center or it's in the periphery, stimulates equal number of cones. So that is why the size is smaller in the center, bigger in the periphery. So once this stimulus has stimulated the retina, you're getting the responses depending upon whether you have given 37 hexagon as your stimulus, or 61 or 103 or 241. This is how the response is going to be. What is the difference? Why not do 341 for everyone? So the difference is that more the number of responses, a normal multifocal ERG almost takes 8 minutes for recording. More the number of presenting elements, more the time taken, more the patient will get fatigued, and more his compliance will reduce and difficult interpretation of the test. So further way of analysis is that the system itself divides it into simultaneous rings. So you can have, this is because some diseases, especially in drug toxicity, this is very useful. So multifocal ERG, and we know that some drugs affect the fovea, some affect the perifovea, some affect the annular area around the fovea. So to know which ring is more affected, this can give us an indication as to which is the disease which could be causing it. So it gives you a topographical map. It is important, though the topographical maps look very nice, it is important that you look at the trace areas, because the topographical maps do not show the true waveforms. So you may lose the detail which is given in the trace areas. The origin, ma'am had told us briefly as to the origin of these waveforms. So largely it is cone driven. It is similar to the full field ERG, but not same. So the negative deflection is the N1 wave, and that is similar to the cone driven system. And the B wave or the P1 is similar to the cone bipolar cells. So this is, as I said, not a true response, but a mathematical extraction. So without taking you too much into detail, the interpretation of the multifocal ERG. So here again, just like in full field ERG, whenever you interpret a full field ERG, you must look at two parameters. One is the amplitude and the other is the implicit time. Usually, the rule of thumb is that a decrease in amplitude means the number of cells responding is less. So there is cell death. But if there is a delay in implicit times, it usually means that cells are present but they are not firing, they are not functioning properly. So this is again the interpretation. As you said, it takes care of the topography. You can see in the first photograph here that it has a central area which is depressed. So central area depression is usually in macular atrophies. And here in the second one, central area is better as compared to the periphery, which is what is the case in retinitis pigmentosa. Generalized reduction you may have in all kinds of cone dystrophies. In localized reduction, you can see the inferior ones are more affected as compared to superior ones, which could be in cases of localized insult to the retinal vasculature, for example, branch retinal artery or vein occlusion. Artifacts, very good question. Somebody had asked, how do you know whether your recordings are good? Look at the waveforms, the shape of the wave. The shape of the waves tells you the story. You don't need a robotic eye to tell you that the one on the left is normal. These are beautiful wavelets that you can see. And the second one, you can see the wavelets, but are they true? No. These are typical three-peaked waves which are coming from the electric noise. So somewhere your electric noise is disturbing and interfering with your responses. From multifocal ERG, you need to make sure any electronic gadgets are not close by which are causing this. Eccentric fixation. So under no circumstances you can have increased responses in one area and normal in the other. This is because the patient is fixating superiorly. So the fovea has moved up, which is why your amplitudes are good in that area. So for this, you have to constantly monitor fixation. In most of the MFERG systems that we are using, this is automatically mapped by presence of a web camera, which is there. If your web camera is not working, do not proceed with multifocal ERG. Positional artifacts, again, because of the rim artifacts or your electrodes are not properly placed, it can cause positional artifacts. With this, let us see how to interpret it. So this is, I don't know why people don't find electrophysiology interesting, but I don't know. I find it very interesting. So if you see mathematically, if you see the right-hand side picture, and the left one, almost clinically, if you see, they look similar. But if you do an electrophysiology, a full field, almost similar. The right one slightly delayed. But if you see the multifocal ERG showing you a generalized depression, you know in the right that there is a generalized depression along with some reduction in full field ERG. So this is what a cone dystrophy in early stages would look. Early stages, you may have cone responses which are still recordable. But the left one leaves you to no doubt that this is largely a macular dystrophy, most common in our part of the country, Stargardt's disease. So here again, full field ERG is extinguished. So it's a patient of retinitis pigmentosa. If you want to follow up the patient and the patient says, am I worsening? How would you do it? So you record a multifocal ERG itself, measure the area or the topographical area where you are seeing responses vis-a-vis the fields. These are two things which can help you progression of disease. Now, there's a lot of interest in gene therapy, stem cell therapy, and in a case where full field ERG is already extinguished in most of these cases of LCA or RP, how are you going to know whether your gene therapy has worked? So here again, multifocal ERG is hugely useful. Most of the clinical trials use multifocal ERG to see whether the central responses are increasing in response to gene therapy. There's another test which is coming up, which is the FST, or the full field stimulation threshold. So we'll not go into that detail, but that again is to look for the follow-up with these patients with gene therapy. Other parameters which can be used in these patients is BCVA, perimetry, FST, and color fundus photograph. Example of occult macular dystrophy. As the name suggests, it's occult. It's occult on fundus photograph, occult on OCT, but it is not occult on multifocal ERG. This is the diagnostic test for occult macular dystrophy, which is caused by heterozygous variation in the RP1L1 gene. It is the test of choice in patients with drug toxicity. Various drugs can cause it. And number one is hydroxychloroquine, because it is the best investigation for hydroxychloroquine toxicity. The AAO guidelines suggest that this should be done in all patients who come to you. I'm sure all of you would have seen at some point or the other. Patients who are having rheumatoid arthritis on treatment with HSQ, they come for screening. So multifocal ERG is the test. Suppose you don't have it, at least a fundus photograph with autofluorescence and a spectralis SD OCT should be done. So these are the few risk factors which you must go through. Another investigation is vigabatrin. These are known to cause drug toxicity. So not to leave the importance in diabetic retinopathy, multifocal ERG is known to be affected even in patients who are pre-diabetic, even in patients who don't have obvious diabetic retinopathy. So multifocal ERG can show you these changes. Because of paucity of time, I'll just go and take you to a few cases of pattern ERG, because that also falls into my talk. So as ma'am had introduced, pattern ERG is a retinal biopotential when retina is stimulated with a pattern, and this is best done with DTL, not done with Verdinel electrodes, because it has got a contact electrode that makes the vision hazy and the patient will not be able to fixate on the pattern. So you have two important components, P50 and 95. If all of you can just take home 1 point from pattern ERG, I'll be happy, and that is that P50 shows you the macular response, N95 the response from the ganglion cells. Ma'am, shall I wrap it in 1 minute? Yeah, just so this is what pattern ERG is all about. Again, as I said, if P50 is down and full field ERG is down, so is normal, so that means it's a maculopathy. Full field ERG is normal because only limited maculopathy will not show up in full field ERG, but P50 is down means it is a maculopathy. And here is the other example, that if you have a macular edema, you can see that here the pattern VEP is low, but pattern VEP is not diagnostic of optic nerve disease, because even a macular test can result in reduced pattern VEP. So pattern ERG for optic nerve dysfunction, how will you distinguish between macular disease? So P50 is normal in optic nerve dysfunction. In macular disease, it is decreased. P50 latency is normal. In this, it is delayed. N95 will be decreased in optic nerve dysfunction, and N95 will be normal in macular disease. So as I said, if you have reduced pattern VP with a reduced pattern P50, only then it's a macular disease. So these are few examples and how you use it to correlate between pattern VEP and pattern ERG. Thank you once again, and I apologize for overshooting my time.